Hello and welcome. Today's presentation is on taking calcium and vitamin D for osteoporosis. So what I'm going to cover today is calcium and vitamin D intakes and blood levels, comparing different types of calcium supplements, how your bones use calcium and vitamin D, and then finally how your body controls blood calcium levels, because it's important to understand how all the pieces fit together. And the timing on this presentation is good because the 2025 World Congress on Osteoporosis just happened in April, so it's a good time for an update. My name is Michael Lavico. I'm an engineer, I'm a researcher, and I'm a patient. I have osteoporosis. But what I'm not is a doctor. So the intent of this presentation is to help you work with your doctor to treat your osteoporosis and hopefully get to a point where you're not going to fracture. So work with your doctor, not a doctor. I have no disclosures. I don't work for a pharmaceutical company or Citracal or, anybody, right? I don't get paid for this. I'm just sharing the experiences and all the research that I've done, so hopefully it will help you. All right, so we're going to start with calcium and vitamin D intake and blood levels. Okay, if you can't wait, here are the answers, right? 1,200 to 1,500 milligrams a day, total calcium, supplement plus food. Vitamin D intake, typically 1,000 to 2,000 IUs gets you in a good spot. And that's kind of that next marker there, the 30 to 50 nanograms per milliliter. The units are key. You want to take just enough vitamin D to kind of get into that range. So if you can't wait for the rest of the presentation, there are your answers. All right, if you can wait, then let's keep going. All right, so on the left-hand side, I'm showing a chart of the recommended vitamin D3, a little bit different than D2, D3 intake from the National Institute of Health. And you can see most of us are going to fit in this, 70 plus type range. And about 800 IUs, international units, per day, or 20 micrograms per day is kind of that recommended, it's really kind of a minimum daily allowance. But just kind of keep that in mind for now. We'll talk more about that in a second. But really what determines how much vitamin D you should get is determined by a blood test. So when you go in for a blood test and you say, oh, doctor, check my vitamin D levels. And they, okay. What they'll check is this, it's called 25-OHD3. So it's what's called the storage form of vitamin D. And it's important. I'll talk more about the details in the backup as far as, what the differences are. But regardless, and there's various organizations with various targets. So it's kind of a moving target depending on who you talk to. And you can see some of the recommendations from the various institutes, like 20 to 50 from the National Institute of Health, 40 to 60 from the Endocrine Society, 20 to 50 from the Institute of Medicine, and they've also gone as far as to say, hey, above 50 might be harmful. And all of the studies that I read, and all the trials and such, what they do is before you start the trial, they ensure that you get to at least 30 nanograms per milliliter, because they know anything below that kind of hinders the performance of even calcium, let alone medications. Okay, now if we look at the chart down below here, there's a couple kind of data points that help firm in this 30 to 50 range. And the first one is from a doctor named Robert Heaney. And what he showed was if you had sufficient calcium, so you have plenty of calcium coming in, and then you changed your vitamin D levels, what he saw was as you increased your vitamin D levels up to about 30 nanograms per milliliter, right? That's equivalent to about 75 nanomoles per liter. So on your blood test, look very closely at the units because it makes a huge difference. You might think, oh, I'm in this perfect range. But if you don't have the right units, you might be way out of that range. So again, look at that. Regardless, what he found was when you go above about 30 nanograms per milliliter, there was no further absorption of calcium. You've kind of maxed out the amount that you can absorb in at this range. So there's kind of one data point. Here's another one over here, and it maps the parathyroid hormone which is kind of that control signal for calcium, right? My blood needs more calcium. Let's send out PTH. And we know PTH is important. And what they found is when you increased your vitamin D levels, this 25-OH level, to about 30, then your parathyroid hormone would settle down, saying, okay, my body has enough calcium. You don't have to, call in the troops to give my bloodstream more calcium. So there's another data point that says, boy, really 30 is a pretty good number. And now if you look on the far right here, and I have it in the backup slide, I'll talk more to it, but this was a trial called the Stop It trial. And what they showed was if you had vitamin D levels below 20 nanograms per milliliter or above 40, you were increasing your risks of fall. Now, it's kind of unclear on why that happens, but there is definitely a risk, and I'll show you some trial data that supports that. So again, 30 to 50 really seems like a good range. And just another data point, an endocrinologist gave a presentation. Her name's Heather Hoffledge. She's out of UC San Diego. An endocrinologist, focuses on osteoporosis, very well-known doctor, very well-respected doctor. She uses this 30 to 50 range as well. Now, when we talk about this 30 to 50 range, this is for building bone, okay, and reducing your risk of fracture, right? So you're not falling, you're making, good calcium input to make good bone levels. However, right, there'll be other studies that say, hey, above 50 might be good for diabetes prevention, or better for heart protection, or some other disease protection. So again, if you have another doctor saying, hey, I want your vitamin D levels higher, listen to them, right? Don't listen to me. 30 to 50 is really that range for bone building. Okay, everything else aside. Now, if, let's say, you get it checked and you're down at, say, 20, well, Dr. Bilezikian has this great tip over here, and he says for each 1,000 IUs per day increase of vitamin D will result in about a 10 increase in your 25-OH. So if you're cruising along at 20 nanograms per milliliter, then you know what? You can just up an extra 1,000 IUs per day and get to 30, or 2,000 IUs a day and get to 40. So it makes it, nice and easy to do this. And by the way, these levels move slowly. So you're really, for it to settle, if you're going to make a change, it takes about 3 months for it to, settle out. So that would be a good period to get it rechecked and kind of see how you're doing. Some people I've talked to in the support groups, they might be at like 70 nanograms per milliliter. I'm like, okay, well, that's kind of high for bones. How much vitamin D do you take? And, I don't take that much. I said, well, check the labels, right? Okay, well, my multivitamin's got vitamin D. Okay, there's 1,000 or 2 IUs there. I take calcium every day, and okay, my calcium's got vitamin D too. Oh, my, milk's got vitamin D. My, drink's got vitamin D. There's vitamin D everywhere because it's a nice selling point. But too much is also not good, right? We're either falling over, or it can also cause the bone resorption, because the osteoclasts kind of get overactive and kind of eat too much. I know we're getting a little bit technical here, but just know that there's kind of a sweet range for bone building. Okay, and again, watch those units. I gave an example down here. Those units really matter. So do the conversion. Look at that closely. Okay, enough for vitamin D. Let's switch gears to calcium. All right. Here are the recommended daily allowances from the NIH again, and you can see the ages and the daily calcium intakes. And 1,200 is a good number. A lot of the studies that are rated, hey, let's make sure we're getting in 1,200 milligrams of calcium, and that could be food alone. It could be a combination of food and supplements. So if you're not getting enough in your food, you want to supplement where you can. Now, I've also seen studies that say 1,500, and I'll talk a little bit about that coming up here on why the 1,500 number. But regardless, what you want to do, I put a little cheat sheet down here. So as an example, 8 ounces of milk or 6 ounces of yogurt contain about 300 milligrams of calcium. A slice of cheese is like 200 milligrams. A cup of mixed nuts, about 150 milligrams. So you kind of want to check not just the dairy, but some of the other foods that you eat to see how much calcium you're getting. I know there are trackers out there and you just put in the food and it kicks out a number. Those are great too. So you can use that as kind of a rule of thumb. When you take calcium supplements, and I'm going to talk about calcium supplements, which one's the best? Bet you can't wait. With food, and especially if you take it with protein, you'll get a little bit better absorption, so that's something to consider. And then finally, you don't want to take more than like 500 to 600 milligrams at one time, because the efficiency, your body can only absorb so much calcium at one time, and you're going to end up just kind of passing it throughout your stool if you take more than that. So your efficiency kind of runs down. You want to sprinkle it out throughout the day. Okay. How much calcium is too much calcium? Well, this is Dr. Robert Haney. He passed away a few years back. He was kind of the god of calcium. Did a whole bunch of testing in the early days. And what he determined was calcium is what's known as a threshold nutrient, which means you get an advantage when you take a certain amount, up to a certain amount. All of a sudden you get, the maximum benefit from it. And, you can stretch that out a little bit. But then after that, you kind of get negative effects. And what he found was about 1,500 was that peak. So when you hit about 1,500 milligrams per day, assuming your vitamin D levels are in that sweet spot, then that's about all you could absorb. Going beyond that wasn't beneficial. And then if you go too high, and some of the articles here on the right-hand side kind of talk about this. And if you want to see a video, John Belazikian, he's another endocrinologist, kind of world-renowned guy that works on osteoporosis. I put a video link here and you can listen to him talk about this. But really, I'll let him tell you, but what he says is basically you don't really have to worry too much about cardiovascular risk at this 1,500 or 1,200 to 1,500 milligram level. It's really when you get up, 2,500, 3,000 milligrams a day where you kind of start running into problems. But again, I'm not a cardiologist either, so, listen to heart first. Heart first. Heart stops, you got problems. Okay. All right. This is probably the most important slide in the deck here because it gets really confusing. Calcium blood levels. All right. So when you get your blood tested, you get your calcium level, right? And you'll see numbers like, 9.2 or 9.5 or whatever. What I did is I put the range here, 8.8 to 10.2. This is the Mayo Clinic's, range, though it will vary depending on the lab that you get checked at. But individuals don't fluctuate this much, right? Dr. Belazikian calls it kind of, every person has their own little happy spot, right? Where their body really wants to be, where the body is trying to control the calcium level to be at. And it's different depending on the individual. So this can move around, but for the most part, your blood levels, your calcium levels are trying to be in this one area. And it might go down a little bit, might go up a little bit depending on how much calcium you have, and the test is a little bit variable. But for the most part, you're kind of in this individual slot here. Now here's a big problem that people will make. And you want to help your brother here, right? Help your sister here. When you read a blood test and it says, oh, my calcium's at 9.2, it's right in the middle of the range, I don't even take calcium, and I've got great calcium levels. Therefore I must be someone special where I don't have to take calcium. No, that is wrong and dangerous, and let me explain why. So your body is really good at doing whatever it can to control that that total calcium number to your happy spot. If you're not giving your body calcium, calcium's used by, your muscles, your heart, all throughout your body, calcium is used. If it can't get it from your diet, it's going to get it from your bones. Your bones is like the calcium bank. And if money's not coming in, it's going to borrow from this bank. And there's no other way around it, right? You don't get calcium. Your body can't make calcium. You can't breathe in calcium. You have to put it in your diet, or it's going to come from your bones. Okay. unlike vitamin D, right? If you take vitamin D and you take a whole bunch of vitamin D, well, it can start storing and you see that 25OH number go up, right? If you take too much calcium or too little calcium, it's really not going to move the needle there because it's got your bones to work with. Okay. All right. I talked a little bit more about how the calcium gets regulated in your body later on, but this is a key point. Now, when you get your calcium checked, the number that they give you, this 9.2 number, is what's known as a total calcium. So it's all the calcium in your blood. It's a combination of free calcium, right? The element calcium Ca2+, right? Just, floating around by itself. And then there's also calcium that's bound to other proteins or other elements. Albumin is a big one, and that makes up, roughly 45% versus this free. And then there's some other, combinations that kind of come and go. So when you look at this calcium that they give you, it's a total calcium. You should also get ionized calcium measured at least once, and I'm going to reference you back to New to Osteoporosis. You really should start there as a training. This is kind of a spin-off from that training to understand, calcium ion and such like that. But so you want to get this checked at least once, but what doctors typically do is they'll look at your calcium number and then they look at your albumin number. And John Belazikian has this, he uses this. This is a calculator, put a calculator link at the bottom. And if your albumin level is greater than 4, he doesn't use the calculator. If it's lower than 4, then he uses the calculator. Because your calcium might come in at 8.5 and you think, oh man, that's kind of low, right? Or 8.2 or 8.0 for that matter. But if you look at your albumin, you might have a low albumin. And that's what's driving that low number. And if you use this calculator, it shows you the corrected calcium number. So this gets kind of technical, but just know if your calcium numbers are off, look at that albumin number. And your doctor should be doing this. But if not, it's you could check it yourself and kind of see where your calcium levels are compared to others. Okay, let's keep moving. All right, comparing different calcium supplements. Ooh, right? Everyone's got their own special calcium. There's kind of a religion that goes along with this. There's a heck of a lot of money that gets made in this area. I might call this the can of worms, and I'll probably lose some people in here for this fight, but let me explain. So when you take calcium, right? Forget about the form for now. So you're taking calcium, swallow it. It gets into your stomach, it gets broken down, it gets sent into your intestines. Your body can't absorb calcium carbonate or calcium citrate in that form. It has to be broken down into this ionized calcium, this elemental calcium that's not bound to anything before it can get absorbed through your intestinal wall into your bloodstream. Okay, I know this looks confusing. There's not going to be a quiz at the end of this, but just know, regardless of the form, right? Regardless of the packaging it comes in, regardless of the promises that are made, right? Whatever they put in that bottle has to be broken down, and the calcium will then be absorbed in. Now you might say, well, shoot, well, my calcium is highly absorbable. Okay, well, if you take calcium with food, that hydrochloric acid in your stomach does a really good job at breaking down just about anything. And from all of the doctors, all the trainings that I've been to, they basically say, look, as long as you take it with food, it doesn't matter. Okay. Now, some supplements have a real good balance of magnesium and, a bunch of other stuff that maybe you need, maybe you're deficient in. Okay. I could see that argument. If you're deficient in those other areas. Other ones will say, well, my calcium's got the right amount of vitamin D, built into it. Well, that's convenient, but you don't need to take calcium and vitamin D at the same time, right? They're independent on how they absorb. Now, there's some confusion here because people say, oh, no, you need vitamin D to absorb calcium. Well, that's true. Your body, your bloodstream needs that storage form to be active, to be able to activate this pathway to absorb more calcium, but they don't need to be taken at the same time. So, and you can see in this very complicated diagram, there is a signal here for 125-OH2 vitamin D3 that activates in the wall of the stomach or in the lining of the intestine that says, hey, let in more calcium because I need more calcium. We'll talk about that control later on. But just know you don't have to take them at the same time. So if you want to spend a whole bunch of money in calcium, go for it. But I'm telling you, it's really not going to help. What I do is I just stick with a major brand, right? Stick with a major brand of calcium. I use Citracal because they have everything to lose if something's contaminated or if you're not getting the right amount versus some fly-by-night place that, who knows where their stuff is being made and they might not be here next year. So my 2 cents, I know I'm sure I lost at least a couple of you here. And there are some, I'll say, cheater calciums out there where they add something called strontium. And that shows up great on the DEXA scan, but there's no proof that that helps. As a matter of fact, I can make arguments that probably that's a real bad idea. So take that for what it's worth. Boo, right? Okay. All right. Now, believe it or not, that's the bulk of this presentation. I'm going to go into some deeper stuff here that gets complicated. So I know I'm going to lose quite a few of you here, and that's okay. But please feel free to post any questions on, the YouTube comments down there. And I'll do my best to answer those or any questions that you want to put there. And also just a quick shout out to Elaine Henderson's Bone Buddy support group. That's where I started. This is where we talk and she has these great courses that shows you how to work out with osteoporosis and such. And on the fourth Saturday of every month, we do an open forum and I attend those, almost always. And we'll talk for like 3 hours. So, it's people sharing their experiences, asking questions, and, I present some updates that might have happened in the last month that I found. So you're welcome to join that. All right, so let's push through. All right, how do your bones use calcium and vitamin D? I'm going to give you the high-level version here, and then you could go deep dive when I do the secondary causes of osteoporosis. But let's start here. All right, so here's a picture of your bone, and this your bones are active, right? All throughout your body, your bones are being what's called remodeled. So there might be an area of your bone that needs some repair, like maybe there's a micro crack, and your body says, or your bones say, hey, I need repair work here. And this happens all throughout your bone. It's a great system. And so what happens is this osteocytes over here, it's a thing inside the bone or maybe on top of the bone. And it sends out a signal that says, hey, I need some attention over here. Please dig out this area and refill it with, new bone. So it sends out this signal and the osteoclasts will start to form. You get these pre-osteoclasts and then they'll attach to the bone. They become mature. They start dissolving bone. So you'll see this, these two little critters or however many little critters, marching along your bone, and it leaves this big channel. And then what happens is these osteoblasts will start to appear and they'll start to kind of rise up, leaving this collagen matrix underneath. So it starts kind of filling in the scaffolding for calcium and phosphorus to mineralize. So that's where calcium comes in here, right? Presentation about calcium. This is how calcium helps the bones. It's available in your bloodstream. When this activity happens, the calcium's got to come through and mineralize that collagen matrix to give you new bone. Okay, now that's pretty cool. All right. What about vitamin D? Okay, vitamin D is in your bloodstream and it can get to these, osteoclasts and osteoblasts, and they have receptors for vitamin D. Now, you see 125-OH2 vitamin D. This is what's known as the active form. I'll get into those details in a minute. But this is the vitamin D that will tell the osteoclast, think of it as oil for the machine. So it helps the osteoclast do their job. It helps the osteoblast do their job. And they're well-oiled, working together and, kind of marching along there. And if the levels get too low, there's a problem. If the levels get too high, they get too aggressive. So again, that sweet spot, 30 to 50, is really good for bones. Okay. How does your body control blood calcium levels? All right, so now this gets kind of complicated, but again, I'm going to go through this just kind of quickly and more details to come. So in this example, let's just take in 1,000 milligrams, just so the numbers are nice and easy to work with. So 1,000 milligrams coming into your, in through your mouth, stomach, into your gut, small intestines, large intestines. All right, so we've got 1,000 milligrams coming in. Of that, about 400 milligrams makes it into your blood system, right? Gets absorbed through that, intestinal wall. And you have this new 400 milligrams, say, coming into your system, so new for the day. Well, at the same time, the gut says, hey, I'm going to take some of that calcium back for other reasons. So it's taking out about 200, but it gives you a net 200 milligrams, new in your blood that your body can work with. So for your heart, for your muscles, for, all kinds of components in your body uses calcium. All right. Now that calcium, like I just showed you, gets circulated through the bones to mineralize bone if it's needed. And if your bones take more calcium than they give back, right, because it's being churned up and kicked out at the same time. If your bones take more than it's being kicked out, you're building bone mass. Congratulations. And that happens when you're young. If you're at bone balance, where you're kicking out just as much as you're putting in, well, you're not gaining any bone density there. Your DEXA scores aren't getting any better. But as you get older, you typically end up on this bone loss side where you have less going in than you have coming out, and you're in bone loss. All right, so what happens to that extra calcium that now we have in here? Well, you end up urinating it out, okay? And likewise on the left-hand side, that the net, you do the math here, you kind of, in your stool, you'll see about 800 milligrams in this example. Okay, so all the numbers add up. That's kind of how calcium works in your body, or gets circulated, absorbed into your body. All right, let's talk about vitamin D. So when you take vitamin D, and by the way, the vitamin D that you take in a bottle, it's called vitamin D3 cholecalciferol. This is the same vitamin D that ends up in your body when sun hits your skin. So when sun hits the skin, it does this conversion of some cholesterol, and it turns into cholecalciferol. So it's the same stuff. It's almost impossible to get enough sun without getting skin cancer. It's almost impossible to get enough sun to get the vitamin D levels that are really necessary to build strong bones, right? Due to population, due to our pollution, due to other factors. So you almost have to supplement, especially if you're dark skinned. It makes it tougher. Okay, so when you take it in, right? So D3 is going in, you take it, you swallow it, it gets into your bloodstream, no problem getting into your bloodstream, and it circulates around. The first stop it makes, where it makes a difference, is it goes into your liver. So this vitamin D3, cholecalciferol, goes into your liver, and then it gets converted to this 25-OH-D3, this storage form that the doctors measure for. And it gets stored throughout your body. It's in your fats and your muscles. It's kind of everywhere, ready to go type of thing. But then it really has to go through one more procedure to be converted into what's called the active form of vitamin D. And this is that 1,25-OH2-D3. Now the kidneys will do this when they're told to. So there's a control signal that's basically saying, hey, I want you to convert more of this because your body needs it. Because this is the D3 that will go to your gut, that will go to your bones, and other places. You have D receptors all throughout your body. That this 125-OH vitamin D is active for. All right, so now let's put this kind of all together. What's controlling all of this? Well, there's something called the parathyroid glands. These glands reside behind your thyroid gland. And, there's 4 of them. And when your parathyroid glands, they sense the calcium ion, right? Not the bound calcium, but the free calcium ion. And it says, okay, Mike has his calcium is low. Mike didn't get calcium today, so I see that it's low. If it does, it will send out parathyroid hormone. It says PTH. So PTH will go down to your kidneys, and your kidneys will say, oh, geez, Mike's low in calcium. I better start converting 25-OH to 125, and at the same time, I'm going to stop peeing out calcium because Mike needs that calcium. The signal is here. Mike needs the calcium. Stop peeing out calcium. Send out this 125. The 125 then goes to your gut, and it says, gut, I need to absorb more calcium, send in more calcium, right? I'm going to allow in more calcium, right? It's kind of like a 5-alarm fire, give Mike calcium. And this 125 will also go, and well, PTH and 125, go to your bones and says, give me your calcium, right? Stick them up. And so your osteoclasts start digging harder, right? You're not recalcifying bone as much because the calcium is now being taken back into your blood pool for more critical things like your brain and your heart and your muscles and everything else. So again, that's kind of how this all ties together in one big picture. I know this is really confusing, and I'll slow down on secondary causes of osteoporosis because there's all kinds of things that can happen through here, right? And you can imagine them, right? What if you can't absorb enough, right? You got some sort of disease where you can't absorb enough nutrients, or what if your parathyroid is messed up, or what if your kidneys aren't controlling things properly? So there's a lot of things that could go wrong here that cause those secondary causes of osteoporosis. All right, now to finish up, just some fun World Congress on Osteoporosis slides. There really wasn't that much in 2025, though I have some slides here from 2024 and one from 2025. Though there were some calcium ones, but they were kind of, for youth and for people with certain diseases and such like that, so it didn't really apply here. But this one was from 2024, and this is Dr. Dawson-Hughes. And she runs, matter of fact, this is her trial. And so she presented this last year. The people in this trial were getting enough calcium, but there were different levels of vitamin D. What they found was if your vitamin D levels, this 25-OH vitamin D, was less than 20 or greater than 40, you had a higher risk of falling and therefore fracturing. So this 20 to 40, again, another kind of data point here that says, 20 to 40, above 40 might be trouble, right? Below 20 is, trouble, and it's trouble in a whole bunch of other areas that we've already talked about. So that's when you start saying, well, maybe 30 to 50, let's push it to 50, even though you're going to be at a greater risk of falling at 50. You do get benefits on other things like pre-diabetes, right? That transition from pre-diabetes to diabetes. If you have a higher vitamin D, that seems to help prevent that from happening. And there are other trials talking about, there are a whole bunch of different things, right? Whether it be strength or whether it be protein absorption or, who knows what. There's a whole bunch of different trials that says, hey, maybe even greater than 50 might be a good thing. So you kind of have to weigh the differences on, okay, what range do I want? 30 to 50 seems to be an adequate target or a good target for bone building. Okay. Effects of vitamin D3 and calcium fracture rates. So this was another study. This is an older study that was done in a nursing home. So the average age, roughly 85 years old, but it was outstanding results. What they found was what they did is they took people in the nursing home, right? And you can see the baseline, the 25-OH was 16 nanograms per milliliter, so quite a bit less than the 30 target I've been talking about. And their calcium intake was only 511 milligrams per day on average. So all they did is they took a group of these people and they said, we're going to give you 800 IUs of vitamin D and 1.2, right, 1,200 milligrams of calcium a day. So we're just going to give you kind of the recommended daily allowance and see what happens. Well, the group that did that, and this is just in 18 months, there was a 43% reduction in hip fracture for the people that took the just supplemented, right, up to 800 IUs and 1,200 milligrams of calcium per day. Now, did it build their bones overnight in 18 months? Likely not. This is more than likely fall prevention that happened here. Okay, again, that less than 20, there was this increase in fall risk. So that's more than likely what explained it. Other non-vertebral fractures was 34% reduction. So, this is kind of the study that got everyone thinking about, geez, I really need to look at this and see if there's a link between vitamin D and calcium and fractures. All right, this is my last slide. This one came this year, so just last April. And this was a short presentation from a guy that was talking about protein, the importance of protein. And so there's 3 groups here shown: no osteoporosis medication, a group, 418 people, 101 people on hormone replacement therapy. And then the last one was on either a bisphosphonate or Prolia, right? So Fosamax, reclassed, Prolia type of drugs. And looking at various scenarios. So looking at total calcium, was it greater than 1200 or less than 1200? Calcium supplements, were you taking supplements or were you not taking supplements? Taking supplements if your calcium was low. In other words, you're supplementing when you're supposed to. And then finally, protein intake. Now, it's technical. There's these things called p-values. It has to do with, is the result significant or not? But you can see a trend throughout this. 1,200 milligrams is a pretty good target, and you can do better as far as reducing your risk of fracture by increasing your hip strength. But the bottom one, the one that was significant, is this protein intake while on either a bisphosphonate or Prolia, where you had much better results if your protein intake was greater than 0.8 grams per kilogram. Okay, so I'm not going to do the math for you. You could figure it out. But the bottom line is you want to get a certain amount of protein in your diet because it will help those drugs when it comes to bone building. Okay, so I thought this was interesting because when you think about it, what are the bones made of, right? What's that collagen matrix made out of? Well, it's a protein. So you need that certain amount of protein levels to ensure that you're getting the protein necessary to make bone. So keep that in mind. I thought that was pretty interesting. All right, so that's it. This one's short and sweet. Again, thank you for your time. If you have questions, feel free to leave them. I'll do my best to answer them. And as always, stay fracture free. Good luck out there.